This is a unique case of a suprasellar dermoid cyst that presented in a patient with acute visual decline. Preoperative MRI scans, as demonstrated here, are highly suggestive of a dermoid cyst, as T1 studies without contrast demonstrate a high-intensity signal within the suprasellar space suggestive of high fat content. Diffusion-weighted imaging, as seen here, demonstrates no evidence of restriction, which also supports the idea of a dermoid cyst over an epidermoid. The midline location and all of these imaging features are highly suggestive of a dermoid cyst. To approach this lesion, we utilized a transsphenoidal endoscopic Endonasal assisted approach. The patient is positioned supine, as seen here, and the head is turned and the nostrils are presented towards the primary surgeon. The abdomen and right leg are prepped for either a fat or fascial autograft if needed. The patient is positioned 180 degrees away from anesthesia, so the primary surgeon and the ENT surgeon have direct visualization to their monitors. As you can see here, the dermoid has expanded the tuberculum and has thinned out the bony surface overlying it. A high-speed drill is further used to thin out the bone. This allows for safe removal of the bone using a caudal elevator and avoids injury to underlying vascular structures that might be in the area, particularly the clinoidal carotid. Blunt microinstruments as well as kerosene rongeurs are used to elevate these bony fragments and remove them from the field. This exposes the surface of the dermoid, and a dural incision is made with a feather blade. Immediately upon making an incision through the dura, the contents of the dermoid cyst are quickly seen and aspirated. These are highly suggestive of compact keratin, which is very unique and common to these lesions. Microscissors are used to further expand the dural opening. This is expanded laterally with careful care not to injure the carotids. Oftentimes a Doppler is used to map out the carotids in this moment of the surgery. Once the dural expanded laterally, double suction technique is used to debulk the vast majority of the dermoid cyst safely. As you can see here, there's immediate CSF egress from the suprasellar space. Further debulking is done to decompress the optic apparatus. As more dermoid is removed, one can see here the pituitary stalk in direct visualization towards the very back of the surgical cavity, with the optic chiasm and the optic nerves superior in the field. Here we can see a thin veil of arachnoid protecting the optic chiasm and bilateral optic nerves, as well as a pituitary stalk right in the midline, with excellent decompression and good pulsations of the brain. Inspection of the surgical cavity in the suprasellar space with a 30-degree endoscope allows us to have direct visualization of the optic chiasm and the intercerebral arteries, as well as the ACOM complex. Direct inspection of the thin veil of arachnoid reveals some residual disease implanted into the arachnoid that can be carefully suctioned without injuring underlying vascular structures, and particularly perforators that are supplying the optic chiasm. Continued inspection of the surgical cavity reveals a small residual of dermoid inferior and medial to the right optic nerve that's causing compression. Careful care is used using microdissection technique with blunt instruments to separate this residual from the underlying clinoidal carotid. Injury to the carotid here can be devastating. Therefore, careful technique is mandatory. Once the residual dermoid is actually dissected bluntly off the carotid, safe planes are elevated and isolated in order to allow for sharp dissection and complete removal of the dermoid that's implanted in this area. Dissection in this area can be tedious and challenging. This requires patience and good surgical technique to remove this last remnant of dermoid that's attached to the critical neurovascular structures in this area. Dissection planes are methodically developed. As you can see here, a ball probe instrument is used to develop these planes in a blunt fashion. Here we use a microdissector to carefully peel off this residual of dermoid that's attached to the medial aspect of the optic nerve. Here we see the peeling of the dermoid away from the medial aspect of the optic nerve with minimal to no stretch on the optic nerve itself. planes here are developed to deliver the last remnant of disease that may have been stuck in the optic canal. And then finally, once the last residual component of the disease has been isolated, the thin attachments of arachnoid that may contain some vessels are isolated and then coagulated. Once this is done, it is safe to use microdissection and remove the last remnant of disease. Upon further inspection with the endoscope, we can identify small implants again in that thin veil of arachnoid. Blunt instrumentation is also used to deliver these small areas of residual disease and aspirate them for a complete resection. As you can see, dermoids have a tendency to recur because of residual disease like this. The surgical cavity is finally irrigated, and a DuraGen inlay is used to reconstruct the dural opening. The DuraGen inlay is placed in a gasket seal type fashion to allow for good opposition to the dural opening. The nasal septal flap is the final layer of closure. This is a pedicularized vascular flap that is elevated off the septum and then rotated to oppose the bony opening of the skull base. As you can see here from post-operative images, there's excellent gross total resection of the dermoid cyst and an excellent decompression of the optic apparatus.